Okay, so we'll get started. So, hello and good afternoon, everyone. Thank you for taking the time to attend this learning session hosted by the Diversity, Equity, and Inclusion Action Team that is focused on creating opportunities for us to learn and grow together. My name is Angela Toomey. My pronouns are she, her, and I am the People and Culture Assistant here at McInnes Cooper. So, as a new member of the DEI Educate Action Team, I have the privilege of welcoming you to this year's Pride Panel presentation. So today we have with us two exceptional guest speakers who will shed light on inequities that persistently and increasingly affect the quality of life for members of the 2S LGBTQIA plus community. They'll also tell us what we as an organization and as individuals can do to be more informed supporters and active allies. Our moderator today will be Moncton Associate Nicolette Beliveau. So before we dive into the topic of gender-affirming care, I wish to acknowledge the Indigenous peoples of all of the lands across Turtle Island. While we meet today on a virtual platform, I invite us all to acknowledge the importance of the lands on which we live and work and from which we have all benefited. I am located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. I encourage all attendees to share and acknowledge the lands that you call home in the chat. We do this to affirm our commitment and responsibility to improve relationships between nations and to improve our own understanding of local Indigenous peoples and their cultures, including those who identify as two-spirited. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all Inuit, Métis, and First Nations people who call this land home.
Thank you, Angela. My name is Andrea Hewitt. My pronouns are she, her, and I am also a member of our DEI Educate team. Before we begin our discussion with Riley and Mari-Lynne, we thought it would be helpful to do a quick review of some key terms. Being respectful of all gender identities and sexual orientations is essential to creating safe and inclusive space. So understanding the spectrum is an important step on the path of allyship. So let's start with the acronym that we typically use in our communications, which is 2S LGBTQIA+. Note that the definitions we're using come from the Glossary of Terms document published by the Canadian Centre for Diversity and Inclusion. And there are many, many, many other terms in that document, to which I'll add a link to the chat right now, so you can refer to it in the future. Okay. So 2S means two-spirit. And so it's an English umbrella term to reflect and restore Indigenous traditions that honor the fluid and diverse nature of gender and attraction and its connection to community and spirituality. It is used by some Indigenous people rather than or in addition to identifying as LGBTQIA+. The teachings, roles, and responsibilities of two-spirit person differs from community to community. Not all queer Indigenous people use the term, but two-spirit is an identity specific to being Indigenous and can only be claimed by Indigenous people. It's very important. I also wanted to say before I started, and forgive me for having not done so, that we sometimes get the question about what's the right acronym, and what I learned through consultation with some of our community members is be as inclusive as possible. The plus really matters because you're never going to be able to encapsulate all, but having that plus is important because every identity matters, and just making sure that we are as inclusive as possible is really important. The next is the L. So L stands for lesbian, which is a woman whose emotional, romantic, and or physical attraction is to other women. Non-binary people may also use the term. And I'm showing the flags for each of these particular identities as well. So gay is someone whose emotional, romantic, or physical attraction is to people of the same sex or gender. More commonly used to describe male attraction to other males, but men, women, and non-binary people may use the term. Bisexual is a term used, sometimes shortened to bi, that describes people who are emotionally, romantically, or physically attracted to both men and women. It can also be used more broadly to describe people who are attracted to more than one sex, gender, or gender identity in any capacity, and not necessarily in the same way, which may also be referred to as pansexual or panromantic. So trans, and this is an important one because it's going to be a key part of our presentation today. So trans is an umbrella term for people who do not identify with gender binary. So this includes non-binary, gender non-conforming, and transgender individuals. And the asterisk is used in written communication to indicate inclusivity. Now, part of that definition includes non-binary. I've referenced a couple times, so I also want to define that. So non-binary is a way of identifying and or expressing oneself outside of the binary gender categories of male masculine, female feminine. Non-binary identities exist on and off the gender spectrum, and it can be a specific or umbrella term. Q. So Q stands for queer, which is an umbrella term used by some who identify as neither heterosexual nor cisgender. It's becoming more widely used within the community because of its inclusiveness and is sometimes used for convenience in place of acronyms, but it should not entirely replace the acronyms. Historically, this term was used offensively as a slur and has been reclaimed by some for use within the community. So transgender people may or may not use the term as queer, may or may not use the term queer, as the community have diverse histories. So this is one that we want to be careful about. It's something that people of the community should feel empowered to use, but because not everybody feels comfortable with that term, people who are not of the community should maybe just be a little bit careful about using that term. And that a definition referenced cisgender, so I want to explain what cisgender is, and that is the gender identity of someone who identifies with the same gender assigned to them at birth. So the term is often shortened to cis or gender normative. Also want to define a QT BIPOC, which stands for queer, trans, Black, Indigenous people of color. And QT BIPOC are acknowledged to it is an acknowledgement that encompasses some of the most marginalized members of the 2S LGBTQI+ community, existing at the intersection of racism, ethnocentrism, xenophobia, queerphobia, and transphobia. Accordingly, QT BIPOC individuals often face multiple forms of oppression. Oops. Okay, intersex. So someone who is born with anatomy, hormones, or genetic makeup that differs from the general medical definitions of male and female. Someone who is intersex may have one or more of a variety of differences that are usually of no medical risk. They are generally assigned a gender at birth by their doctors and family, but this is becoming an outdated approach. And then A, the final letter in the acronym that we use, stands for asexual. So someone who experiences little to no sexual attraction to others and has little to no interest in sexual activity or sexual relationships. Asexuality exists on a spectrum and can fluctuate, and it is sometimes shortened to ACE. So then on to some broader definitions. So gender identity is how someone internally, mentally, or psychologically perceives their gender. Someone's gender identity can align with or differ from the gender they were assigned at birth. Someone's gender identity can change over time as they learn about themselves and learn more terminology. Gender identity is distinct from biological sex. Very important. Misgendering. So that is the act of referring to someone, whether intentionally or not, with a term that does not align with their gender identity. This includes using the wrong pronouns. So that's why, as you'll see throughout this, some of us speakers are revealing our pronouns. Many of us have done so in our email signatures. So making sure that we share those, but then that we also respect and utilize them when they are shared with us. Another thing that is relevant to misgendering is using a trans person's dead name, and that would be the name they were given at birth, but does not reflect their gender identity. Or using gender terms like sir or ma'am, care letter. So this is all very modest progress, but even the announcement last week suggests there are significant challenges to accessing care in our region due to an extreme shortage of physicians who provide gender-affirming care services, which is why it references the need that many people have to leave the province. And it's a major issue that's finally getting attention thanks to people like Riley and Mari-Lynne, and they're the experts. So I'm now going to turn it over to Josie to introduce them. And thank you so much.
Thank you, Andrea. My name is Josie Hunt. My pronouns are she, her. I'm also a member of the DEI Educate team, and I have the pleasure of introducing our speakers today. Dr. Mari-Lynne Sinnott is an MD, a certified member of the College of Family Physicians, and a graduate of Memorial University. She has 7 years of experience as a community-based physician serving the 2S LGBTQIA+ community and co-founded a network of downtown cooperative clinics working within community organizations to provide inclusive and complete primary care to the marginalized populations in the city of St. John's, Newfoundland. She holds a part-time faculty position with the Family Medicine Department of Memorial University and is involved in teaching both medical students and residents as one of the main preceptors of the Care of Underserved Populations Enhanced Skills Program. She also sits on the board of directors of Trans Support Newfoundland, Inc., and as a member of the Eastern Health Trans Needs Committee. She has other ongoing qualitative research and works with other team members on academic projects. Riley Nielson-Baker is a public servant and student of public policy and governance in Nova Scotia. They have a Bachelor of Public Management from Florida Atlantic University, a Master of Public Administration from Dalhousie University, and are a current Master of Arts in Political Science student at Dalhousie. Their research interests include transgender people in Canadian law, the rural-urban divide, and in anti-oppression efforts in the public sector. Riley works in the field of long-term care policy and has worked in the field of gender-based violence as a program coordinator, providing support for survivors grounded in trauma-informed and whole-of-community practices. They are the recipient of the 2021 Roselle Green Award for Public Administration Excellence from Dalhousie University. And Nicolette Belville is a lawyer in our Moncton office whose practice focuses on labor and employment law and insurance defense. During law school, Nicolette was consistently at the top of her class, and she completed a judicial internship at the Court of Appeal of New Brunswick under the direction of the Honorable Justice Charles LeBlanc. Nicolette is a member of the Law Society of New Brunswick, the Canadian Bar Association, and I apologize, my French is not good, the Association des Juristes d'Expression Française du Nouveau-Brunswick. I'm very sorry for how bad I probably butchered that. As a member of our Educate Action team, Nicolette has been helping to organize DEI learning opportunities such as this for the past 2 years. Outside of McInnes Cooper, Nicolette is a volunteer director for the Greater Moncton SPCA and for French for the Future. She is also a member of her community choir and greatly enjoys traveling and the culinary arts. Sorry, I'm getting over COVID, so I'm losing my voice. On behalf of everyone at McInnes Cooper, I welcome and thank you all for joining us today. I now invite Nicolette to open the discussion with our guest.
Thank you so much, Josie. As stated, my name is Nicolette Bellevaux. I'm an associate in our Moncton office, and my pronouns are she, her, elle. And Josie, I just want to say your French was really fantastic. You did a fantastic job pronouncing that. So thank you so much for introducing all of us today. So I'm just going to jump right in. And what I'm going to do, Riley and Mari-Lynne, I'm going to alternate. But if at any point you kind of want to jump in on another question, please please feel free to do so. So I'm going to start with Riley, and we're going to start with a really, really broad question, open question, just to get this discussion going. So Riley, what would you say are the most significant limitations on the rights of transgender or non-binary people in our region?
So the most significant barriers that we see here at Gender Affirming Care, and while we typically focus on health equity and access, it is not the full scope of the issues, but I'm going to start with health equity and access. It's nearly impossible to access a doctor, nurse practitioner, or other healthcare provider here in Nova Scotia, here in Atlantic Canada, who is a member of our community, has ever met a member of our community, or let alone knows how to practice medicine on a member of our community. And I always use the example of, if you, a cis person, were in a car accident tomorrow, went to Emerge, and your doctor looked at you and said, I don't know how to practice medicine on you. I don't know how your medications will interact with what I want to do. That would be unacceptable. But that's the reality we're living here in Atlantic Canada and here in Nova Scotia. We need to address these huge systemic barriers that basically make it impossible for us to access general health care, let alone gender affirming care. We're also looking at issues such as discrimination in employment. We're also looking at issues such as increased homelessness and houselessness. We're looking at issues such as increased or higher levels of debt than cisgender counterparts. We're also talking about issues of as simple as not having inclusive gender options in applying for things as simple as housing or really anything. I can list on like one hand how many organizations I've gone to that actually use an extensive option in their gender selection, such as X or other, with X being preferable. Now think about if you want to apply for housing. Your options are either, in many situations where there is no inclusive option, your options are to misgender yourself or out yourself. Which is not ideal, especially when we're dealing with a society that is incredibly transphobic and homophobic, but especially transphobic. Outing yourself can really eliminate opportunities for you in employment. It can limit your opportunities in applying for housing. It can limit your opportunities in really all aspects of life. And recognizing that this goes far beyond gender affirming care, and gender affirming care is life-saving care and can actually make it easier for people to address these barriers to access. Having a body that better aligns with your gender identity can actually make it harder, and it's a very complex issue in the community itself, but it makes it harder to be clocked. It makes it easier to go stealth and not have to out yourself constantly in every interaction that you have. We here in Atlantic Canada, while we in some aspects are much further ahead of the curve, and I'm looking to Nova Scotia being the province with the highest percentage per capita of trans, non-binary, and intersex people, again, self-identified, so the actual number and percentage is definitely higher. And I'm looking at, I believe Fredericton has the highest percentage of any municipality of our community. We're a little ahead of the curve in that, but we are still incredibly behind, as is all of Canada, in actually creating a world that is accessible to members of our community. We also need to look into issues such as, there's just so many issues, I'm sorry. It's impossible to really comprehend the entire systemic process of discrimination. It starts with small things such as not being able to have your gender identity recognized on your driver's license because there is no option, or applying for housing because there is no option, or being discriminated against just for existing. And dealing even with people who may be less hostile to trans people, still having internalized biases that can help limit their ability to access care or any part of this region's systems. We're also talking about increased barriers to access when we look at this as an intersectional issue for especially members of the QT BIPOC community. They are more likely to experience decreased access to healthcare, decreased access to housing and employment, increased debt, increased houselessness and homelessness, just for their identity as being members of the Indigenous or Black or other racialized communities, let alone being a member of the trans, intersex, or gender diverse community. It's all basically I always use the analogy of it's like a tangled string, or like when you get your headphones tied up in a knot that's just impossible to untangle. Even when you pull one of those, one of the strings to help undo one knot, you're still left with an entire system that is hostile, openly hostile to members of our community. That's kind of where we are.
Yeah, thank you so much, Riley. And I think it's really, you raised so many good points, and it's like you said, everything is interconnected and everything is a system. And like you said, we might, focus on one specific piece, but it doesn't address every other piece that all work together, because that's just how the system of our society was designed. And as we can see, it takes time to make those changes. Mari-Lynne, did you want to add anything to that there? I see you took yourself off mute.
I was writing notes because
Fantastic.
I was like, am I going to remember all of the things that Riley was like sparking in my head? So just a couple of things will probably come out as we're chatting anyway, but I think that a lot of the same issues that are faced in Nova Scotia, of course, we see in Newfoundland, particularly just accessing care and accessing like clinically and culturally competent healthcare providers, and across the geography. And so in Newfoundland and Labrador, we have a lot of rural and remote areas, especially in Labrador, where there are no providers, or the only providers that go to those areas or are residents who have not been exposed to much in terms of providing, gender affirming care, or just, inclusive, culturally safe care. And so that's just a continual barriers that people face in trying to access providers. So I'm the only provider in St. John's and really in Newfoundland that's providing almost exclusively gender affirming care. But I guess my viewpoint is that gender affirming care is primary care, and they're the same thing. So it's hard for me to say, like, I don't really think I have a specialized practice. I just have a primary care practice, and I see mostly trans and gender diverse people. And the way that happened was, I guess, pretty organically. Like, I had no intention to have that be my practice, but when I opened my practice, I knew that was kind of just like an area where there wasn't a lot of people providing the care. So I was like, oh, I'll do it. And I guess figure it out as I go along, and I did. And then the more that I did it, I guess, the more people, word of mouth is a really powerful thing in small communities, of like getting to know like who's safe for you to go to. And as you build like credibility and safety as like a reputation, I guess, of cultural safety with the community, they'll say, yeah, she's good. Like, you can see her. I started to see more and more people. So, like, I would say about 50% of my practice population right now is trans and gender diverse, which is probably about 700 people, but it's probably like 75% of my day, because there are more complex needs in that community, because for many of them they have been so underserved for so long, and care has been inaccessible in every way for many people in that community for a really long time. So I see a lot of complex healthcare needs, a lot of mental health issues that are, existing in addition to social issues and physical health issues. So it takes a lot of time, and the system isn't really structured to reward me for the time that I have to spend with people. So figuring out how to do that in like a fee-for-service community practice is quite a challenge. There's no other family physician in the province right now that's doing what I do. There are a couple that do like a certain amount of it, but few and far between, and I'm reaching the point where I don't know like what my limit is of how many patients I can have, and can I continue to take new patients, because I'm continuing more and more to see new folks, new transgender and diverse patients looking for transition related care. And I don't know what my limit is. I guess right now I'm like pretending that I don't have one, but I do, because we all do. And how do we empower and educate and help like the up and coming medical learners and residents, not just to like understand that it's their obligation to be culturally competent in a way that is inclusive of gender identity, but that like they can do this and it's within their scope of practice. And we are doing that in a lot of ways. We've made really good advances in the curriculum here. But then how do we retain those physicians? So like I have learners with me regularly who by the time they're finished do feel like they can incorporate this into their practice, but they're not staying here. they're not staying in the Atlantic provinces, and they're definitely not staying in Newfoundland. So I think there's many layers to the issues of like why is care so hard to access geographically, and a lot of it has to do with having providers who are competent and retaining the providers and helping reduce the systemic barriers to treatment and the gatekeeping that often happens when healthcare providers and policies get involved. And then I guess the other point that I thought of when Riley was talking was like, we also see issues, I think, accessing safe and inclusive space in our schools in terms of like how students can socially transition safely with or without parental knowledge or consent, how they use the bathrooms, how they feel they can use the bathrooms, how do people access gender inclusive space when they're traveling and the airline only has 2 gender options, and like what do they do then when none of those are a fit? Same thing for housing, same thing for a lot of different applications. And then my question always is when people ask me how that should be done, it's like, why are we even collecting that data? Like, why does it even matter? Who cares what my gender identity is when I'm buying a ticket to go on a plane? Like, it literally doesn't matter. But we have historically collected that data for so long that there's like a sense institutionally of like entitlement to that information when it's not relevant or important a lot of the times. And there's a conflation of collecting data on sex and gender as though they're the same, and they're not. So yes, I guess I have lots of thoughts and probably not a lot of organization, but that's it.
No, that was great. And Riley, I see you raised your hand, so I think you want to jump in on that point because I saw you nodding very vigorously at Mari-Lynne's point there.
It is so important in this discussion about data collection. I come at this as someone who has worked specifically on issues of equity and access, both in healthcare and in programming for government. It is so important to question at every point, why are we collecting the data that we're collecting? Are we collecting it because we're supposed to, or are we collecting it because we want to actually try to impact issues of access, equity, all of that? So many times have I looked at things that government is doing, both in my department and other departments, and it's the first question is, well, why do you need to know? Why is that your business? Why do we need to be collecting that information? Are you doing anything with it? No? Then stop collecting it. And it's a huge conversation in racialized communities, and it's a huge conversation in trans communities, especially you looking at racialized communities such as the Black and Indigenous community, where that data that was collected was used to hurt them. We have to focus on if we should be collecting the data at all, and if we should, how specific we are approaching this. It's very important to recognize that a lot of the times it's none of anyone's business. I use the example, there's a health food store by my house that I go to frequently. And when I wanted to sign up for their points card, they asked me, am I male or female? In their thing. And first of all, only male or female, so that's a whole problem. But the second question is, why does my health food store need to collect that information? Does it change anything? Does it change the number of points I'm getting? Is there any reason to have that information? No? Then don't collect it. We don't need to have this information, especially if it's not being used. It's a waste. It destroys trusts in communities. And why would we want to do that unnecessarily?
I think that's a really great point, Riley. And I think it's a really, important reminder to us to make us aware, we are, as lawyers and legal professionals, we are drowning in data all the time. And do we need the data that we're maybe asking for? I think I'm now reflecting and I'm thinking of, all the data that, we need and we request. And, I'm going to think a little more critically the next time that I go and get some data. So I thank you for raising that point. Mari-Lynne, you had your hand raised there, so I'll let it jump back to you.
Yeah, I think what I wanted to just add on to that was that, this is a thing that I often talk about when I do education with other healthcare disciplines, was that like asking questions and like taking your history, like ask questions that are clinically relevant, and don't assume that you need to know all the information or that you're entitled to know all of the information. And if you're asking something that's personal, that may make somebody feel uncomfortable or unsafe, then you should probably explain why it's clinically relevant to even ask the information. It's just like weighing people without their consent. We weigh people all the time. We don't need that information half the time. It's just the like programmed fat phobia in healthcare that we have all been subjected to, that we then perpetuate because we think it's evidence-based without questioning the evidence at all, because it doesn't exist. And when I talk to learners, that's one of the first things that I suggest is like, when if you have to ask somebody a question about their gender or their sex or their genitals or their bodies, like make sure that you actually need that information and not just because you feel entitled to it. I have a patient, this is an example I always give, as a patient who went to emerge with a broken wrist and had an x-ray and was diverted over to the emergency room, and the triage nurse was taking his information and asked what medications he was on, and he said he was taking testosterone, and she asked why he was on testosterone, because he like appears very clearly masculine and has that privilege, and so he said that he's taking it as part of his transition. And she then asked him, did he have a penis or a vagina? And he was like, well, I have a broken wrist, and that's really the most important thing, and you actually don't need to know that information. And actually kind of got into like a bit of an argument with the nurse, who felt extremely entitled to the information. I'm within your circle of care, and not really understanding the limitations of that. And this is a person who like truly was empowered enough to speak up for himself in a way that many trans people wouldn't, because accessing healthcare is such like a deeply traumatizing experience for so many of them, that they often just kind of like go along to get along, even if they're feeling extremely uncomfortable. And so he challenged that idea and didn't I think help her really understand it any better. But in another person who's had other negative experiences, that might have been the thing that made them walk away and not access the care that they needed, or it might be the thing that makes them think the next time they need emergency care to actually not go, because the last time this happened, I don't want to go through that again, so I'm going to sit home with this thing that needs emergency medical treatment and probably have a worse outcome because of it, which is like a very quick snapshot into like why we see worse health outcomes in trans and gender diverse populations, because they don't have equitable access to care. And there's a real barrier to understanding, sometimes institutionally, like, well, this service is there, anybody can access it, but that doesn't make it accessible for people who really need it. And there's not a lot of consideration historically given to like how care is accessible within the context of a person's life, as opposed to, we have this building and you can go there.
And I can say, like, I have avoided care because of that. I am very, very lucky to have one of the few NPs in this province as my healthcare provider, my primary care provider, who primarily works with members of our community. And one time she was unavailable and the clinic said, oh, just go to a walk-in clinic. I said, no, I'm not going to do that. I'll wait, because I don't want to expose myself to that unnecessarily. Like, this is something that is so frequent that if you know a trans person, I guarantee you they've done that. I guarantee you they've done that.
Yeah, definitely they have. And that's that's all what speaks to the cultivation of like culturally safe space for people to access care. And when they have those experiences, it informs future decisions about whether to access care. And people don't often think about the very like small roles that they can play in shaping that, because it's as simple as asking someone like, what's your name and pronouns versus not, or asking non-relevant questions because of like morbid curiosity and feeling that a trans person's whole life and body is up for your like perusal and education when it's not. And those are the things that create the negative experiences that result in people not accessing care in the future. And that's it's hard because people feel sometimes it's really overwhelming and it's a lot of stuff to remember, but it's like extremely straightforward. Like, ask people questions that are medically relevant. When someone tells you who they are, believe them, use their name, use their pronouns. Like, it's actually super straightforward, and people get like, oh, this is no new information, and don't you think people should be patient with us? Like, no, people don't have to wait for you to catch up. That's not how it works. And in no other circumstance would you ever, like Riley said earlier about like if you had any other health issue, you wouldn't have that experience. Like, it would be completely different. There would be no situation where you go in with like an infected toenail and your doctor goes, I don't know anything about that, you're gonna have to go find somebody else. If they didn't know how to fix it, they would figure it out.
Thank you so much for that. And I think it's a really important reminder that, a very small action can have such a huge impact, either positively or negatively.
Yeah.
It can kind of go in both directions, right? So we, have to be, aware, culturally competent, and really take the time. And it's, as Riley was saying, reflect on the why. Why are we asking these questions? Why are we seeking out this information? All of those things, because a lot of the stuff we do, I think, is really just automatic. We do things in a certain way because that's the way we've always done it. And why would we change it? Well, obviously there are reasons to be changed. These need to be changed. So if we take that extra moment and kind of reflect, it can have a really huge positive impact on that. Mari-Lynne, I wanted to ask you a question specifically. You raised it earlier. I'm curious as to, some of the specific barriers or limitations to gender affirming care in the context of, in Atlantic Canada, in our region, we do have a lot of, we kind of have a lot of rural areas. And I wanted to bring that because, we're talking about St. John's, Riley, we're talking about Halifax, we're talking about Fredericton, we mentioned Fredericton, so we're talking about the urban centers, but outside of those urban centers here in our region, we have we have a large population that live in rural communities. So maybe you can speak to that a little bit.
Yeah, we do. We have a large population. I mean, about half the province probably lives in the like St. John's and surrounding area, and then the other half is pretty spread out over the rest of the province and Labrador, of Newfoundland and Labrador. But there's a handful of providers who will, do things for like their patients. But the bigger issue, and I imagine it's the same in Nova Scotia, is, 1 in 4 people don't have access to a primary care provider. And so that kind of layered on top of them being in a geographically remote or rural area, with the current cost of gas and barriers to travel, makes it really hard for lots of folks, and especially young people, to be able to access care. And especially if you're, a 14-year-old who wants to find access to gender affirming care, but you haven't told your parents yet, and you live in somewhere rural and you don't have a family doctor. So how do you even start, and where do you go? And nobody should be no one should ever be a solitary provider of any service. My greatest nightmare, and probably the greatest nightmare for a lot of my patients, is what if something happens to me? Because then where will they go, and where will they get services? And also, people have the right to pick the physician that is the best fit for them. And I am not for everyone, nor is everyone for me. And right now we're in a situation where if I'm the only point of access, then people don't have a lot of autonomy ultimately when it comes to accessing care. And so those of us that are doing the care are doing our best to be as accessible as possible for patients. If you're in Labrador, if you're in a rural and remote area, it's very challenging, not just for the travel, but we're not equipped for appropriate virtual care in the community, because the fee-for-service practices have never been set up like that. And then trying to access it through a health authority, where I then have to get myself into a health authority institution, and then the patient has to get to a health authority institution. And then what if somebody is at home and doesn't have internet or doesn't have phone or phone minutes, and like all of the requirements for people to be able to access care like presumes accessibility that may not be there. It presumes like financial accessibility, it presumes geographical accessibility, and a lot of it's a huge challenge for so many people, and I don't necessarily have solutions other than to say that, you know, we have to address the primary care crisis, and we have to build capacity within our healthcare providers, and not just physicians, but my focus would be on physicians, but it's more than just putting curriculum into the medical school, which we have done. There's probably about 4 hours of training now in medical school here that is specific to care of trans and gender diverse people, which is not enough, but it's something. And there are clinical training opportunities throughout medical school and family medicine residency. But family medicine residents they're not the only specialists that are going to encounter trans people, but they're the only ones that seem to have prioritized it at all as something that they need to build competency on. So the medical training and the training of our current and upcoming healthcare professionals is one piece, but also like how do we retain providers in rural areas so that they can access the care? How do we like augment virtual care services so that it's accessible to people who are in rural and remote areas, because it's probably not ever going to be feasible to have providers in every single place where people are. But I would say right now the province is a mess of trying to figure that out for primary care in general, and then from there all of the more like I hate to say specialized, because I actually really strongly feel this is not specialized care, but it's perceived as specialized care. That is a whole other layer of complication. And I have done my very best to like promote this as another piece of primary care. And it's so funny to me that any doctor would be like, oh, I don't know anything about those medications. It's like, you prescribe those medications in cisgender people all the friggin' time. It's just you don't understand them in trans people, which just means you don't understand trans people. And that we can fix, we can help, but you have to actually want to do that. And there seems to be this real like reticence of like, oh, I don't know how to do it, so I'm just not going to, which is a really, really big problem. And I've been trying to like push back in I guess it's more just assertive, it's not passive aggressive, but if somebody lives outside St. John's in particular and they have a family doctor and they come in to see me, I usually will see them one time and chat with them and give them information to review and understand about hormones, and then I'll send a letter back to their family doctor and say, look, I saw this person. They said they're trans, I believe them. It's that simple. And here's how to prescribe hormones, because there's a real perception that there's some big process that trans people should have to go through to be approved for hormones. There's no test that we do to see if somebody's really transgender. There's no special thing that they have to say for me to be like, okay, you get hormones, but you don't. But there's a perception that there is, and sometimes there's a perception from healthcare providers that they're supposed to be looking for certain like symptoms or things to justify prescribing them, when it's simply an informed consent approach to care like every other aspect of healthcare. If this person says, this is my gender identity, these are my goals of transition, I understand all these things about hormones, I understand these risks, I understand these effects. For me, the effects that I seek are worth these possible risks, and that's a risk I'm willing to take, so I would like to start. That's the same as we do for literally any other intervention in healthcare. It's the exact same thing. And for some reason, there's like a perception that it's like more than that, and that, you know, there's a big psychological assessment that people are supposed to go through and hoops that they're supposed to jump through, which just becomes gatekeeping, which of course has worse outcomes for trans people who are high risk moments trying to access care. And so fighting against that with our healthcare providers, and also with like loved ones and schools and all the people that are supposed to be supporting trans people, has been like a big challenge, and continues to be a challenge. But if we are using an informed consent model of care, then this really is extremely straightforward, and it's just a matter of understanding that. And so I try to send letters back to the doctor saying, hey, I saw them, this is all super reasonable, here's how I prescribe hormones, here are the guidelines, let me know if you have any questions, but like back to you, because you're their primary care provider and this is your job, so do it.
And hopefully slowly but surely that approach will, you know, convert that 1-2 people to start doing it, and maybe we'll see, you know, a domino effect.
Yeah, and hopefully we can find ways to retain the residents that are like learning this now and saying, yeah, I'm going to do this in my practice, but then going to like Ontario.
Well, that's it. And I think, you know, I think that kind of the healthcare, primary care issues and almost it's nearly, or it is a crisis. I think it's all over our region. So it's part of a bigger issue, but it comes back to, you know, we were talking about intersectionality again. You know, everyone is having difficulty accessing healthcare right now, but superimpose all of these other challenges and barriers that have been put into place, it makes it even more challenging to do so. I just want to, there was a question that Riley, thank you so much for answering in the chat, and I'll just read it out for everyone so they can see. So Gavin asked the question, what are we referring to when we refer to specialized care? And Riley responded that any healthcare for our community is often referred to as specialty care. So that was just in the optic of Mari-Lynne's comments there. I have two last questions. Oh, sorry, go ahead, Mari-Lynne.
I was gonna say it's more of like a perception of it being specialized care, and I've had that said to me before, especially when I first started in practice, and I would like call a specialist to ask a question like, would you see this patient for an orchiectomy or whatever, and a number of times the specialist will say, you know, it's, you know, you should really have this person referred to a center for excellence. And I'd be like, okay, well, that doesn't exist. So it's me, I'm the center. And there's like this perception that it has to be more heavily specialized and regulated than it really does. And unfortunately, that also impedes access, and it impedes the idea of like empowering primary care providers to envision and use it as part of their primary care service.
Gavin, I see you asked if you could follow up. You absolutely can. So go ahead. Go ahead.
Thank you so much. I'm concerned that the concept of specialized care is being used as a discriminatory factor with respect to the community. When you get right down to it, most medical care is specialized care. I mean, you don't go to a dentist because you need a knee replacement, and you don't go to an orthopedic surgeon because you've had a stroke and need to have some sort of neurosurgical care. So it seems to me to be a very bizarre categorization of the medical services that the community requires to simply say, well, they're specialized, so therefore you don't get them.
Yeah, and it's a way to kind of let yourself off the hook for as a physician for like having to provide, oh, that's a specialized service, but it's really not. And sometimes I think the challenge for parents and loved ones, especially of minors, when they're trying to help them access care, is that like fear of wanting to make sure you're doing the right thing for your child often impedes you from doing the right thing for your child, and feeling like you need to be able to predict the future and know for 100% certainty that this is what you need to do, this is who they're going to be forever, and questions that like nobody can actually really answer. But the more hoops that they jump through and the more assessments that they have, it sometimes is extremely reassuring to parents. I think, oh, they saw X number of specialists, but it's like not necessary. And in the meantime, how much suffering is this person enduring? We have really good data that's done in Canada that shows like the highest risk time for trans youth in terms of depression, suicidal ideation, and suicide attempts is the period where they're planning but not yet begun transition. So it's that time where they know who they are and they know what they need, but they're not able to get it. That is the highest risk time, and it's usually because there are other people, whether it be like their loved ones or the medical system, impeding their ability to access.
That's helpful. Thank you for that.
Yeah.
And it's important to note too that it's right on the money to say that it is a form of discrimination. And part of the problem that we'll get into with one of these last questions is there are very few options for people to challenge these issues. One of the things that GACNS also often does, and I can say this because one of our members too is currently doing it, is human rights cases. But the problem is right now, and I came about this with my own human rights case, is that there is all the lawyers in the province who will take on human rights cases, especially pro bono human rights cases, because practically none of us have the money to afford our own legal support. There aren't any solicitors who are willing or able. The ones that are able or who are willing are not able, such as Dal Legal Aid is one of the primary providers of challenges in Nova Scotia for our community, and they are well beyond capacity. We would love for people to go and do charter challenges and go and do human rights cases. The feasibility of someone doing that on their own, especially challenging the provincial government or another provincial government or a territorial or even the federal government without legal support, is very daunting and often makes it nearly impossible for the case to go forward, let alone succeed. But we can get into that a little bit later.
Yeah, and I guess on that, we're almost out of time, but I want to ask each of you just kind of a question to kind of close the loop on this. So I'll go back to you, Riley, and it piggybacks off exactly what we were talking about right now. So what can allies do to help lobby for policy change? So you were mentioning, you know, legal challenges and all that, but what are some other things that, you know, we can do to help
Absolutely.
with that?
So honestly, it's not even just about policy change, because policy change comes out of societal change, and that's something that we need to reflect on. It is important for all of us to be vigilant in the things that we see, even if we're not a member of the community, even if we don't know a member of the community. If you see some, and I'll put it bluntly, bullshit, if you see it, call it out. I always talk about how it is, a friend of mine once put it as, ally is not a title. And if you think it's a title, who gave you that title? Who gave you the right to use that title? What have you actually done to earn that title? We always emphasize that ally is a verb. Ally is action that you're taking. Do not call yourself an ally unless you're actively taking in your everyday life approaches to actively dismantle systems of oppression. Part of that is if you see something in your daily life, like you're applying for something and you see that they are asking for someone's gender at all, let alone only having male and female options, make a comment. Even if you don't know a member of the community, make a comment, because it requires people who are not members of the community emphasizing problems for our problems to be taken seriously, because we're so historically disadvantaged that the chances that we are in positions of power is next to none. I know one other trans person who's a senior policy analyst at the government of Nova Scotia. The other one is me. Like, we are not in these positions of power. So we need to emphasize the positions of power that we do have. And I always talk about weaponizing privilege. If you are in a position to weaponize your privilege, I weaponize it all the time as a white person, as someone who is cis passing for most of my life. And for someone who has a high level of education, I weaponize my privilege all the time to open the doors for the people behind me. We have to, as a community, recognize I am in a position of power, especially lawyers. Lawyers hold so much power in Western society. There is so much power that is held within having a law degree and being a member of practice, especially if you're someone who has connections. Use your connections. There's nothing wrong with doing that. If you know an MLA, call them out. Ask them what they're actually doing. Ask them to take action. If you and it doesn't even need to be that big. It can be small. Are you, when you're doing intake for a client, asking for their pronouns? Are you only asking for their legal name and sex, or are you asking for their actual name and their pronouns and how they prefer? I say prefer generally. It's not proper practice, but who they are. Or are you just asking what is legally showing on their license? And it's really, at the end of the day, about taking your position of power in this society and turning it back as a way to uplift and weaponize your own place in this world to make it better and easier for the people behind you. Instead of pulling up the ladder, as we always hear, your job should be to put handrails on the ladder so it's easier for the people who are struggling behind you to climb it too.
Thank you so much for that, Riley. I really like the handrails on the ladder analogy. I think that illustrates it really well. Now we have like 2 minutes left. Melanie did ask a question in the chat, and it's for Mari-Lynne. So I'll get it to you, and we'll answer that briefly, and then we'll do a wrap up. But so she asked with respect to training. So what training could we add to the curriculum, pardon me, in medical school to help address these systemic issues? And she knows that there seems like there may be some gaps currently in the training.
Yeah, I think we've done a pretty good job so far anyway at starting to implement things. And I've been here for 6 years, kind of like pushing and yelling at people until they do things. I don't, not a lot of fun at parties, like, because people do stuff like gender reveal, and I'm like, so let's talk about that for a second. But in the med school, I have been able to push with some of the really, really empowered and informed medical students. So we now have in the clinical skills training in first year, it's a lot of just like essentially learning how to talk to people and learning how to like create supportive and like safe environments. And so we have now a clinical skills case that gets brought in first year of a young trans person who's moved to St. John's and is trying to access transition related services. And the purpose of the encounter is like not to offer the medical care, just to be gender affirming and just to talk about like what that looks like and how to be gender affirming and how to like ask people who they are and believe them and support them, and to understand like what resources are in communities for people who need that. And then in second year, we start to implement discussions of hormones and how we start puberty blockers and hormones and how we do referrals for surgery and that kind of stuff. And that's tested material. So that's material they actually have to learn because it's on their exam. And in family medicine, there are some like mandatory education on trans health as well. Then we have what we have started doing, and then it'll be implemented this year as like a mandatory part of the rotation. But any family medicine residents who are training in St. John's, when they're on their 4-month community family medicine rotation, they will have to do a longitudinal rotation with me 1 day a week where they have to come to my clinic and provide primary care to trans people. And so I guess like to answer your question, it's like creating mandatory education and like having it be just a part of the curriculum, and what we're in the process of doing now is kind of reviewing all of the lectures given to the medical students through like an EDI lens, including the lens of gender diversity and gender and inclusion, to make sure that when we're talking about things and we're even just like other health issues and we're talking about like reference ranges on blood work that's typically divided based on sex, and do we actually even need to do that, and having those discussions in the medical school and making people start to think about it now is like super important. But I also think that another big piece is that there's also a ton of people who are out in practice already, and they're going to be in practice for the next 20+ years, and they don't know anything about this, and they're like the biggest culprits in perpetuating like unsafe space. And how do we access them, and how do we like force them to like know better and do better and just be better? And that's a bigger issue. I think it's much harder to do. But one of the things that the college has done to address concerns in other underserved populations is they have hinged our medical licensing on doing education in certain courses. So a couple years ago, it was mandatory to do a safe opioid prescribing course. This year, it was mandatory to do a Indigenous health and safety course. And so you could not get your medical license to practice without doing that. And so what I and a couple of others are currently in the process of trying to like talk to the college about is creating a mandatory course. And we don't have to create it. There's really great, like Transcare BC has a really great module that they could do, for example, that it covers gender diversity and in primary care and just like in healthcare in general, and make that a mandatory aspect of licensure to force them to be educated about it. And you know, you're not always going to get everybody to take it home and use it, but we have to find ways to make this understood to be a mandatory part of healthcare provision, because ultimately I think that if you can't be culturally safe and inclusive, I don't think you have any business practicing medicine. And we have to find ways to hold people accountable to that.
Thank you so much. I think that caps off everything. Thank you both so much for your time. I'll pass it off to Andrea to do just a brief thank you and wrap up. But personally, I just want to thank you both for your time and your insights today. I know I learned a lot, and I'm going to come away from this and really reflect on a lot of things that, you know, maybe we did in the past and what we can do to change in the future. So thank you.
Well, thanks for having us.
Yes, thank you so much. I really appreciate your time and your effort and your patience with us as we did all the preparation for this. I learned so much, as Nicolette and others did, I'm sure. And I have so many questions even still, you know, some things like around, do we even have anybody who has the ability to service our Indigenous communities with that layer of intersectional knowledge? Yeah, because you referenced Labrador, and I'm thinking those rural communities are sort of doubly impacted. Another question I'm holding, and maybe this is for a future conversation, is what can we as employers also do to ensure that our benefits are reflecting that gender affirming care, and it's not just sort of the obvious things like hormones and top and bottom surgeries, but also things that were referenced at like the walk-in vigil the other night, Riley, like laser hair removal or just bone restructuring, all these things that are part of holistic care that help people sort of align with their identity. And I did put a link to the policy there so that people can continue to educate themselves about all of the different things that should be included in holistic gender affirming care, and encourage people to read up on that. And I just want to really accentuate one of the points that you made earlier, Riley, and that is about gender affirming care is life-saving care. And I would love to have another conversation about that, but you know, part of it is surely about people who aren't accessing the care that they need because of the fact that they are going to be discriminated against or going to be forced to answer questions that aren't relevant to their care, or sort of the mental health issues that you referenced, Mari-Lynne, around particularly among youth, and just very vulnerable to those pressures and challenges at that particular time in their lives. So thank you so much for educating us. Hopefully everybody will walk away and continue to learn and really sort of earn that allyship designation, and that we really are actively trying to create change together. So thank you so much.
Thanks for having me.
Thank you.
Thanks everyone. Take care.